We also in our commissioners. Deputy Secretary of Public Health Services Nilesh Kalyanaraman has left his post with the Maryland Department of Health, and we wish him the amazing best. Unfortunately, his departure happened just a couple of days before this meeting. I think he did it on purpose. But we are very, very fortunate that the acting Deputy Secretary of Public Health Services, Dr. Elizabeth Crum, who's sitting here to my right, was willing to make this a priority and come in person to this commission meeting, and we're very grateful to have her. She has really well-established knowledge of the public health system in Maryland, as well as the healthcare delivery system, and we're eager to get her up to speed on the commission and certainly to have her join us in the months ahead. Also here, or also representing, is for the Deputy Secretary of Behavioral Health, Alyssa Lord. She's designated a proxy or delegated a designee for her presence here on the commission, and that's Ms. Sharon Lewis, who may be joining us as well. But so those are the new commissioners who are joining us. Thank you very much for your time. And I'm going to now move to Michelle to ask her to go ahead and conduct a roll call. And I'm sorry, I should have said this earlier. And if I didn't, we need to start it. We will be video recording this meeting. And if you know, your continued participation is your consent for the video recording. So thank you for that. And the video recording will be posted on our commission website at a later time. Did we start the recording already?
Yes.
Okay, thank you. Sorry, I should have said that first. Thank you then. All right, Michelle, please roll call.
When I call your name, please respond with here or present. Delegate Heather Bagnall. Camille Blake Fall.
Present.
Sorry, Christopher Brandt. Dr. Mina Brewster.
Here.
Jean Drummond. Senator Clarence Lamb.
Here.
Dr. Matthew Levy. Sharon Lewis.
Present.
Dr. Dushanka Kleinman. Acting Deputy Secretary Elizabeth Crum. Dr. Oluwatosin Eloteju. Here. Dr. Maura Roseman. Dr. Nicole Rochester.
Here.
Michelle Spencer.
Present.
Alan Twigg.
Here.
Quorum.
Wonderful. Thank you. Thank you. Thank you for all of our commissioners. Stayed steady and present throughout. I really appreciate your ongoing participation and really wise contributions to our work. Let's move then to some business items to get the meeting kicked off. If we could have a motion to approve the agenda that had been sent out electronically, and that's also available as meeting materials on the website.
I move to approve it.
Okay, thank you. May I have a second? Thank you. And if there's no discussion, any discussion on the agenda? All right, then I'll move to a vote. All in favor of the commissioners, all in favor, please say aye or raise your hand digitally.
Aye.
Thank you. All right, any nays or abstentions? All right, thank you. We've adopted the agenda. We'll move on now to the review and adoption of the minutes from the May 20th meeting. The minutes were sent out via email to the commissioners and are also posted or actually are available for review. If there's any call for amendments. All right, hearing none, I'll take a motion for approval. Thank you.
Second.
All right, we've got a first and a second, and if I could just call for a vote, and all in favor of the minutes as is? Aye.
Aye.
We get all the commissioners to vote just for sake of.
Aye.
Thank you.
Aye.
Great, thank you, thank you. I know it's tedious, but I appreciate it. Thank you. All right, so then we'll move now into commission updates by Shane Hatchett.
Okay, I have just a couple things to go over with before we jump into our voting and the slate here. But just a reminder about where we are in our timeline. We at this stage are nearing the open comment period in which we'll be releasing the recommendations. It mentions June 6th here on the slide, and that is a goal that we have to get those posted tomorrow. However, we are planning no later than Monday, June 9th, and I'll talk a little bit more about that in a bit. But part of the reason for that potential delay is as we're making sure that the slate that gets posted matches up with all of the discussion and the changes that we've had along the way. We're also integrating some rationale based on the information that was submitted by the work groups for each of those draft recommendations to help provide context for members of the public and others who are interested in these recommendations so that they have a bit more of understanding about what the intent of this was. And so that will take us a little bit of time. And so potentially we're going to maybe delay that just a couple days, but it'll still be for the full 30 days as required by the statute. So when we come back on July 10th, we should have quite a bit of the public or open comments available for us to kind of discuss and sort through, as well as any sort of changes relative to the recommendations that might be needed. So during that intervening time, work groups may be consulted. And of course, August 21st and the month of September will really be dedicated towards us getting to a place of agreement and consensus around the final report and the various drafts. So that's kind of our cadence through the summer and where we plan to go. You'll note that even though our final meeting is Thursday, September 25th, which we are requesting folks to be in person for that, I do have listed here, post September 25th as a date, just in recognition of the fact that, yes, we submit the report by October 1st, but the work does not end there. The commission's work certainly continues through June of next year, which is when it sunsets based on the current statute. And there will absolutely need to be a great deal of work going into the implementation and coalition building, as well as reporting back to the different stakeholders who've participated in multiple ways throughout this commission's time. So there definitely is more work to do. It's just that this type of how we do the work will conclude and be rebooted and inaugurated in a different way. So as Mina noted, we wanted to make sure that folks were aware that Dr. Kalyana Raman has stepped down from MDH, and so we do have the acting deputy secretary, Elizabeth Crom, here with us, and working closely with her staff to get her integrated into all those different points where we were working with Nilesh. And wanted to also acknowledge that Vanessa from the workforce work group, as well as one of our integration points with MDH, is here and has been really instrumental in that. We also have been working diligently as a support staff with the report writer and a couple of their team members. We have a very early draft that we're beginning to sift through. Excited to get that into the hands of the co-chairs here shortly so that we can start to get their reactions. And then, of course, we'll disseminate information and more opportunities for input very soon. But wanted you to be aware that we are working on these things in parallel and not doing it sequentially. So There is a little bit of opportunity for things to kind of get mismatched along the way. And so one, I'm asking you to help us stay accountable to what the latest version of whatever the recommendation language is or whatever we've agreed to in terms of narrative. Please do remind us if we've misstated or misremembered that. But also to let you know that that does kind of create a bit of pressure on you folks as commissioners, because we're asking you to, do these things in tandem. So apologies about that. But that's also the nature of where we are with these, the short timeline that's still left. As I mentioned at the top of my segment here, we are about to move to the open comment period, which is statutorily required for 30 days. We are planning to get that posted no later than June 9th, and that will run through July 9th. We will publicize this in our post-meeting press release, as well as on our website. And of course, sending this out to our local health department partners, MHO, academic partners, etc. So we certainly do want folks to avail themselves of this, to provide us that feedback. And so we are trying to get that out. I am aware that as we were doing with listening sessions, there was an interest in paid advertising and media coverage. And unfortunately, with where we are financially and just the state of play, that's not really feasible. But we are doing our best to spread the word through digital media as well as existing networks. And so similar to the public comments during the listening session back last fall, we will offer folks the opportunity to provide the comments online at this bit.ly URL. So that's bit.ly/COPH comments. And that will take them directly to the Google form that we'll create. However, if you pull it up now, it's going to take you to our website because it's still under development. And the QR code, of course, will do the same. And then we are also setting up voicemail to receive recorded comments as well for those who might have different accessibility needs. Again, in transparency, I want to acknowledge that while it would be ideal for us to be able to offer and receive comment in multiple languages, our resources don't allow us to do that. So that's something that we will acknowledge in the write-up of our final report, that while we would have wished to be able to do that, and it certainly is aligned with our goals and values as a commission, where we are today, both in our timeline as well as the limited resources we have, it's not feasible. So I just wanted to be transparent about that so that folks weren't surprised or felt like we weren't honoring what we had talked about earlier this year when we were doing the mission, vision, and values work. Oh, and you will note the statute, this period, we are calling it an open comment period because we are inviting folks from all audiences to participate, not just lay members of the public. We want to hear from a variety of individuals. So, if there are word choices today or nuances that you feel are not addressed in the language that ultimately ends up getting approved today, the open comment period is certainly a viable way of providing that feedback to us. And we will take those comments and get those triaged out to the different work groups or appropriate areas for review. The statute does acknowledge that not every comment will be something that impacts the work that we're doing, but we are to focus on substantive comments. And those must be addressed as well as included in our final report. And so with that in mind, for substantive comments, we are viewing those as suggestions or feedback that is actionable, it's meaningful, as well as providing some sort of influence on the development of the recommendations, as opposed to, kind of generic sentiments or emotional responses per se. So we want to help drive folks to making comments that will allow us to operationalize what it is they're saying. And so that's an important distinction to make there. I believe that is the last I have. So happy to take any questions.
I think we had a couple of questions. The Secretary of Health for the state of Maryland now is Dr. Meena Shashamani, and she is not acting, she's permanent. So that was one of the questions that came up in the chat box. Another question that came up in the chat box, submission of comments. We'll defer to the support team on how that mechanism is going to work, but we have to do it in a way that is feasible for managing workloads, but we will try to make it as accessible as possible. And individuals can submit comments to the email address for the commission if they're not able to utilize the form that we make available for commenting. Thank you. All right, so let's move over now, just as a refresher and of course to reintroduce for those commissioners that weren't here for the last meeting. The purpose of today's meeting, ultimately, after I guess there's a baby born, or this is a university.
It does the usual monthly welcome
I see.
to
All
keep
right.
us awake in case we're not in.
Sorry. Little chime went off in the room and it reminded me of my hospital. So the purpose of today's meeting really is to get us to a place where we now have recommendations to post for the 30-day public comment period. With the exception of a few that we're going to review first, all the recommendations that we will consider have already been individually considered and voted upon. So I think that's really important because we're not here today to debate the merits of an individual recommendation. That process has already happened and that voting has already happened by the commission for those recommendations to be moved to a slate vote approach in today's meeting. So please keep that in mind. We will, as Shane referenced, we will be receiving public comments during the public comment period. And if there are, commissioners or members, other members of the work groups and so forth who want to continue to provide comments on individual recommendations, we would encourage you to use that mechanism to do so, so that all those comments in aggregate can then be considered as we look to tweak the recommendations while preserving the substantive content of the recommendation that was already voted upon by the commission, by the commissioners. So thank you for keeping that in mind. Given that, we will first address 6 recommendations that didn't make it or we weren't able to fit in the last meeting. And so they got carried over to this meeting or were evolving from the recommendations we received from the assessment team. So we're going to go through that first. Shane's going to present them and then we will vote on them individually to be advanced to the slate, which will be the second part of the meeting, right? And so we'll vote on them individually. The ones that we advance to the slate will become part of the slate vote that we will have in the second part of the meeting. So thank you. And I'll pass it over to Shane to start that process.
Sure. And just to clarify, 2 of the 6 recommendations are resubmissions based on previous action taken by the commission, and 4 are brand new in terms of review. As Meena mentioned, we weren't able to address them in the previous meeting. So I wanted to note that since our first recommendation that we will be reviewing is, sorry, switching screens here. FND 054, which is the revisit core funding formula recommendation. This was recommitted to the work group and they resubmitted it with this amended language. The recommendation is that the local health officers shall review the adequacy of the core funding model in terms of proportional allocation to each jurisdiction, percentage of local state match for each jurisdiction, categories of public health activities eligible to receive core funds, and any other areas that will benefit from updating the current model that was formalized in the 1990s. Next is CCR 055, placing public health navigators in the community. The language is create non-clinical friendly resource hubs within brick and mortar public shopping districts where residents can learn about and access assistance with a variety of health-related needs. These spaces would be serviced by community health workers, have state-of-the-art technology, and be able to provide information on a variety of topics like home health for elderly populations, when to consider mental health assessments, and how to access them if needed. The benefits of screening for medical and dental health, and many other public health-oriented activities. Next is CCR 056, primary care support. The recommendation is to develop a formal incentive program for primary care physicians to work in Maryland, especially in rural areas. Next is CCR 058, assessing and strengthening public health laboratory system. The recommendation is to assess the capacity of the laboratory system to meet Maryland's public health needs. Next is CCR 060, county level assessment and capacity building. The recommendation is to conduct an in-depth assessment of county level funding models, service delivery activities, and capacity to fulfill foundational public health services to identify successful models that can be used in other settings. And the final recommendation is a resubmission, CCR 065, Public Health and Primary Care Continuum, which was recommitted to the work group and resubmitted with this language, which reads, acknowledge and support Maryland's local health department's provision of basic primary care services in counties where there is insufficient access to health care. Together with the provision of foundational public health services, these services contribute to Maryland's health and healthcare improvement initiatives. Governmental public health is an essential component of Maryland's continuum of health, well-being, and healthcare. Are all of them for review?
Great, thank you. So as we've done in previous meetings, when we are considering recommendations for adoption for the slate, after an initial review of the recommendations, we go and then all of the commissioners should have received a QR code or a link to a poll where you can vote on the individual recommendations that are presented as we go through each individual one. So I'm just gonna wait for everybody to have that pulled up. Sorry, I'm gonna need to do that myself. Okay, so let's go through as everybody can work on that. Actually, Shane, do you mind? Or let's go through this first one, and I'll entertain any discussion we want to have about this or any suggestions for amendments and so forth. And then we'll move into the voting process when we feel like we've had the discussion we've needed. All of the commissioners, you've received the rationale submitted by the work groups or by the assessment team. So if no discussion, then we'll move into a vote. And I think, Shane,
There's a comment.
okay. So Alan says he's unable to join the link. Try to fix that, Alan. Give us Alan, you were able to join in last time though, right?
Yes, I didn't have any trouble before.
Okay. Is anybody else having trouble hearing online?
I can hear just fine.
All right. If for anybody who's having trouble hearing online, you might want to restart or rejoin the meeting and see if that helps. If it's just one person, I think it sounds like most of the people online can hear us well enough. Okay, great. Okay, all right, we'll move into the poll. Please cast your vote if you haven't done so already. Okay, great. Thank you, Dr. Rochester, for that. Is there a passcode?
I apologize, I got called right when you had, how do I store?
So in your email,
Okay.
Shane had sent
Yes, you did.
the
Okay.
link or,
So you know, what, let me go on my phone.
and there is a passcode. So when you link, you might want to copy the passcode first before you click on the link.
Okay. You can also use your phone to scan the QR code in the email. Okay, perfect.
Ellen, any difference? Were you able to log on?
Yeah, apologies. I'm just getting an error message, cannot connect. Shane did send me a new link. Thank you.
If you want to verbalize or chat box your vote, while you're waiting, to figure out the whole thing. You can do that.
Thanks.
Great.
I
Thank
too
you.
am having problems, and so I will, Shane, send my vote to you in the interim. Thank you.
Michelle?
Yeah, it's Michelle.
Okay.
Thank you.
I love how we've gotten to know each other so well. I can recognize your voice. Did everybody have a chance to vote? The first one's always a little rocky. Everybody's getting linked in. Everybody's good? All right, all the commissioners had a chance to vote? All right, thank you. I think once we have enough, then Shane will make the vote. He'll call the vote.
Okay.
Okay. All right, so then we're advancing that to the slate for review. Mine actually looks different than what's on the screen there.
Oh, sorry.
Okay.
I went too far. So we have, it's giving me percentages, but 77% in favor and 22% cannot support. So
Okay.
it's a majority.
All right, great. And for the record, Commissioner Brandt joined us as well. So, hi, Chris.
Thank you.
Okay. If any other commissioners have joined us, sorry, I can't, I may have missed it. So please, if you wouldn't mind announcing yourself so we can mark it for the roster. Okay, all right, let's move to the next recommendation if we're ready for that.
Placing public health navigators in the community, CCR 05. Any discussion?
So when this came in, was there, evidence, right? Because this is really good stuff. We actually do this now. And it is, especially when you have, it's called navigators or from that community, it's economics, it's very, very helpful. We're putting folks in housing units, but I was just kind of curious. We can all vote, or let's say this is voted to go in. What was with that? So that ultimately whoever sees this can say, wow, this is evidence-based. This is not just something good to do, but this is something.
So I don't know if you look at the materials, they would have provided the rationale associated with it, or if this came from the assessment team, maybe.
Okay.
I can just make a quick
Oh, yeah,
comment.
great, thank you.
The assessment team found that one of the cross-cutting findings was that there wasn't enough visibility of the public health operations of local health departments. That there needed to be more public visibility of what they do and what resources they have. And then the other cross-cutting finding was that we really don't have a very preventative oriented system in general, and there was a lot of comments about how can we move toward that. So this was a big, creative, long-term solution to both of those findings, where people would be trained and able to answer many of the questions that the public has and be very accessible, that people wouldn't have to go to the local health department, but they could go next door to where they shop or where they are or where they, so it was kind of a creative solution. It'd take a lot of work to really operationalize it, but I'm really glad to hear that steps are being made to make it real.
Yeah.
So,
Excellent. Thank you so much. No, it's no question. It works. I'm happy to, yeah, it works. It's important. It definitely, yeah, it's a gap that, absolutely. Thank you. Thank you so much.
I just had, I think it, from a recommendation standpoint, I think it may be helpful for this to specify who is the executor of this recommendation. And so it might be, I would recommend, amending the language of this recommendation for the recommendation to be that local health departments, as the responsible entity, establish, and I don't know that it needs to even say non-clinical, right? Because what if it's appropriate to introduce a clinical element into the resource, right? So I would just say that local health departments establish resource access points within brick and mortar community sites, and such as public shopping districts. And the reason why is because not every county has public shopping districts anymore, or things that are recognized as public shopping districts. And so this would be more inclusive, I think, of some of our rural areas in particular, where we may not have those types of resources.
So can I ask, with the same brick and mortar, could, folks think, okay, we've got to build that, or is that clear? Because I'm thinking we've got their existing, I mean, even we've worked in dollar stores, did some work in Mississippi with the Mississippi Riverboat around diabetes. Right. Riverboat, diabetes, come on, Jane, what's the connection? To where people went, right? The non-clinical though, the reason why I do kind of like it, I'm clinical, but the reason why I kind of like it is because, one, it's all about the trust. And if you need that clinical, you go on upstream, you get to the public health department. But sometimes it's grandma who, could serve as this clinical health worker. Everybody knows her. She's been in the community for a long time. And she just has the ability to she knows the cultural, the geographic, just all of that. And so it could be, I don't know if it's clinical and non-clinical, but I love that non-clinical piece just because
You don't want to lose the emphasis.
I don't want to lose the emphasis there. And it's intended to be a track to get to the non-clinical. And so I just kind of thought, I would love to, I see the state-of-the-art technology there. I kind of like, I mean, I just don't want anything I guess when the folks that are gonna put the money towards this, read this, will they look at it and say, yes, it's good, but do we really have the money for that? Because sometimes our health departments aren't even at state-of-the-art, right?
Well,
And I don't have any problem with it, I'm just.
I think Tosin had a comment, and then I'll speak.
Yeah, I just wanted to add to what Nina said, so as not to limit the type of staffing. This space, the third line, this spaces would be serviced by, we could repeat, public health navigators, such as community workers, because some jurisdictions might utilize community health educators, and so especially with the shortage, we don't want to restrict it to just the scope of community health workers.
Yeah, and I think just to thank you, Gina, I think your comments are great, and I really appreciate the concept of not losing the focus on non-clinical. it's just from a, actual delivery
Mhm.
perspective in the community.
Mhm.
Sometimes what draws people to a particular access point initially
Is
is the availability of something. Maybe it's a diabetes test, or maybe it's a blood pressure check or something like that. And so we've found in our community, at least, that when we are out there with community health workers, that even having something there might draw more people, and then we can really focus on the other aspects of
Okay.
wellness. So I was just suggesting not to restrict it, but again, this is a recommendation, and I think to your other point about, prioritization, of course, those decisions need to be made by those local health departments, and they will have to prioritize things. These are recommendations that the commission is making so that we can make improvements to the needs in the public health. But certainly this will be balanced amongst all the recommendations.
Okay.
Yeah, just a clarification point. So the revisions that you mentioned here, I mean, with those changes, I would support, but are we voting just on the language here to advance, or how do you?
It depends on how we adopt it. So if we put it forward and say we're gonna vote on the recommendation as just with amended as discussed, then we would be voting on that language. And again, this isn't final language because we still have a public comment period to move through.
And to add to that, sometimes the poll would reflect, it just depends on the time. Sometimes the poll will be amended by Shania, who's, really working on it to capture some of those languages.
Otherwise, the support team looks back at the discussion and tries to capture it after the vote. I thought I saw a comment from,
Yeah, Sharon mentioned that Deputy Secretary Lord would like to request additional information regarding fiscal impact and existing efforts that may already be underway.
so were those submitted along with the rationale for the recommendation? Okay. Then we could certainly look into that further, because some of this is going to depend on the different local health departments' perspective of what the fiscal impact would be. I don't know that we would defer voting on this recommendation at this time until, just because we have a timeline to get through for here, but we can certainly do that during the public comment period, identify what some of the fiscal resources might be associated with this recommendation. Great, thank you. All right, so any other comments on this? Okay. All right, well, hearing none, let's move on to a vote then. And the vote will be for this recommendation. Everybody's comfortable as with the amendments as discussed?
And so that is to amend it
To
with
say,
an LHD focus and remove specificity about the provider /
well, that the recommendation would include the executor, which would be local health departments. This should establish, resource access points within brick and mortar community sites such as public shopping districts, where residents can learn about and access assistance for a variety of health-related needs. And then emphasize the community health workers piece as a component of, as Tosin was mentioning, as a component of the types of workers that could be staffing up these types of.
Is it it? Is
I
it
think
it?
he's trying
Oh,
to
yeah.
type in some of the amendments for it. Thank you, Shane.
So the last one was advanced.
Yes, the last one. Okay.
sent me a note indicating he approves.
Great. Well, if everybody's had a chance to vote, then we can move on to the next one if announce what the result is for the.
This will advance to the slate.
Okay, Great. Moving on to the next recommendation. This is for primary care support. And this is a recommendation to develop a formal incentive program for primary care physicians to work in Maryland, especially in rural areas. We'll step into discussion here. Like the previous one, I would recommend an executor be added into the language of this recommendation. And in this case, perhaps, and I'd be interested in our MDH folks to comment, perhaps it would be the Maryland Department of Health develops a formal incentive program. Or is it the legislature establishes a funded formal incentive program? We probably need to discuss that.
This is through, you know, the Medicaid program, or just, we're just kind of saying do it.
The finding from the assessment team was that 60%, and this has to be verified, 60% of Marylanders don't have a primary care, or have a primary care, only 60%. And among those who do, it's very hard to get a primary care doctor's appointment. So it was an effort, and rural areas are disproportionately affected. And part of the refrain that we heard over and over again is there's no incentives to go there. There's no incentives to practice there. I think MedChi is trying to work on this problem, but it's more than the Medicaid population. It's a general population issue. So I think to study it and to develop a, you know, some sort of incentive for it.
Hi, this is Chris Brandt. I wholly support this. I would just add a mention of partner with the rate setter. Or partner in partnership with the Maryland all payer model. Don't call it rate setter, actually, please.
Thank you, Chris. Tosin?
Yeah, I would just ask that we amend physicians to providers. There's significant data to show that not only physicians, there's a shortage of physicians and NPs. So that would help, you know, with the workforce, because you know, Maryland, nurse practitioners have this prescriptive authority, right? So that would help with access in rural areas as well.
And PAs.
So
yeah,
NPAs, yes.
You know what the word is called, CMS calls it eligible providers. That's the terminology, it's eligible providers.
So I would suggest, just in light of some of these comments, maybe it would be helpful for the recommendation to read as that the Maryland Department of Health is in collaboration with essential partners develop formal incentive programs for primary care clinicians to work in Maryland, especially in rural areas. Is that okay?
And then Dr. Rochester, Heather.
Okay, thank you.
Thank you.
Okay.
Actually, I appreciate clinicians. I was just going to say, as a physician, and I know this isn't just my stance, many of us have an issue with the word provider and kind of being lumped in, while very much appreciating our advanced practice practitioners. So I appreciate using that term, clinicians. I think that's a nice way to put us all in that one category. Thank you.
The department does have, I'd say, formal incentive programs in this space. So I guess I'm just thinking about as you're amending the recommendation.
Do you think, then should we say establish or enhance? Because I think the issue is that even though those incentive programs are there, they're not addressing the need that's there, right? I mean, there's still an incredible maldistribution, I would call it, of primary care clinicians across the state, including a general lack of sufficient primary care clinicians.
And with funding threats now, we could see those decrease over time. So maybe continue to support or enhance
Do you think that would be better language to say, develop and enhance?
We have to think about what the fiscal impact is of that on the
Sure.
enhancing piece.
Right. I mean, some of this is that if it's led by the state health department, they research options, identify what options are, what are the components of that, and then it kind of leads to a collaborative solution development. And to Chris's point made earlier, that there may be some opportunity to leverage resources that are already in the system overall for the purpose of advancing primary care access. Senator Lamb.
Yeah, so there is a program, the Maryland Loan Assistance Repayment Program, the MLAR program, that initially was for physicians, and I think a couple years ago was expanded to include nurses, and I think does include maybe nurse practitioners and PAs, but it's underfunded, right? And so I think in part it's funded by physician licensing fees that go into the Board of Physicians, I think.
Right.
And then it's oftentimes rated to cover other parts of the budget. So, there's a couple $1 million, but it doesn't cover what, the need is. So it may be more just kind of enhanced funding, which, I guess falls back on the legislature.
Any other, so if we, based on that, if, I was recommending just to have a singular lead that brings together the necessary partners in a collaborative way and so forth. And then we can add in the word enhance so that we acknowledge that there are existing mechanisms, but perhaps there could be additional mechanisms as well as improvement of the existing. Okay. Shane.
So to confirm the language that I heard, amend this to MDH in collaboration with essential partners establishes/enhances rural access incentive program for eligible clinicians.
For primary care clinician. And maybe, I don't know if eligible is in this context, maybe it's not.
Okay, primary care.
So, all right, thank you, Chris, and Chris left, I think, an important comment that this is a national issue, not just a Maryland issue. We're seeing concerns about the future workforce when it comes to primary care as hitting a crisis point really across the country. Okay, thank you, Shane, and we'll move to, if no other discussion, we'll move to a vote.
This will advance to the slate.
All right, over to the next recommendation, Steve.
DCR 058, assessing and strengthening the public health laboratory system. We will take discussion.
Can we get a little background on this, please?
Sure, just really briefly, this is an area in which the assessment wasn't complete enough for us to make specific, to create a specific summary of the current status of the laboratory system, but we heard anecdotally that there were issues with timeliness, with comprehensive capacities within the laboratory system, that samples were, not viable when they got to the place where they needed to be tested. So the issue of not having enough, not having the capacity. So it was just an effort to call attention to the fact that we need to strengthen the laboratory system and assess it in a way that can drive those decisions about how to strengthen it.
Thank you. And am I, so public health laboratories, we of course have our central, like, state public health laboratory that has the majority of the role. But we do have laboratory capacities at various local health departments as well. And the system relies upon currying of samples between state and local. So I'm wondering if this recommendation is only geared towards the state public health laboratory, or is it just in reference to the totality of the public health laboratory capabilities in Maryland, including the local levels?
I think it's more at the local level. And I think that the state, but I don't think you can ignore the fact that there is a state system that is supposedly interacting. The other, I guess, elephant in the room is the private labs and the contracts that between LabCorp and Quest and
Right.
how those all interact. It's just that we couldn't ask enough questions to really understand what those capacities were. So this is calling for a little bit deeper dive on that particular issue, just because it has such an essential impact on surveillance of communicable diseases, for sure, not just, cholesterol levels. I mean, we're talking, we need this sample tested because there's an outbreak in this community and that sort of thing.
Okay, thank you. So is the executor of this a request to the legislature to fund an assessment of Maryland's laboratory capacity in the, for the purpose of serving public health needs in the state?
It could be, I don't know enough to, I think someone who's more familiar with the status of it might be able to tell you whether or not it needs to go there or whether they can just start it without legislative support.
Thank you. Any additional thoughts, any, specific language revisions people want to propose to this recommendation?
Maybe, we could say, use existing resources to assess, that way it's, not new funding. New of all the other funding requests, if there is capacity.
So like whose resources?
Well, I don't know, maybe starting with MTH versus, because that's a big request. That's, because it's gonna be tough to get down to all the LHDs.
Any thought from our engaged team?
I just think it would be hard with existing resources.
Resources, yeah. But I have to say, this is a very good recommendation, especially with all the, imagine public health threats and, threats to like capacity, just nationwide. I think this is very, very important. We need to continue to assess either way.
I would suggest that if we really feel like this needs to be done, Dr. Levy is joining us as well. Thank you, Dr. Levy, for being here, and thank you again for your hospitality. If we truly feel like this is a recommendation that is needed, which I think obviously it's coming from the assessment, so there's the data to show that it's needed. The recommendation should be mandated, right? I mean, we can't rely upon existing resources, otherwise we would have done it already, to assess the capacity of Maryland's public health or of Maryland's laboratory system in meeting Maryland's public health needs. So I would recommend that the recommendation read that the legislature establish the funds to support an assessment of of Maryland's laboratory system and its capabilities or its ability to meet Maryland's public health. And Delegate Bagnall, I see you've joined us as well. Thank you for joining our commission meeting. Great. Is anybody opposed to that, amended language, or should we vote on that? Very quiet. All right,
Mhm.
you're ready to move on to the slate, I know. Okay, are there any other comments or discussion on this? Concerns?
None online.
All right, well, hearing none, are we okay to move to vote?
So to confirm, the amendment is the Maryland General Assembly appropriates funds for an assessment of the public health laboratory to meet Maryland's public health needs.
Maybe, yeah, not the public health, we were talking about the public and private, so maybe the laboratory system or the state's laboratory system to meet Maryland's public health needs, or ability to meet Maryland's public health needs, something like that. I like the language you used in fitting that, it's much more appropriate. Thank you. All right, we'll move over to a vote.
Oh, Maryland's never mind.
Eight to two, this advances to this, sorry, 9 to 2, this advances to the slate.
Okay, and is this the last one?
One more after this.
All right, second to the last. All right, county level assessment and capacity building. So Shane read this out already.
Any discussion?
I guess I'm a little confused by this recommendation as to,
Nina, again, this was just a point that the assessment team didn't have enough time to really assess the different funding models that counties had with their local health departments.
okay, that's all.
Some were county, like some got some money from the county to do X, Y, and Z, some did not.
Right.
And it was just unclear as to how that particular aspect of the public health system either I think it bolstered the local ability to execute the foundational public health services. But in other counties, it didn't seem like it was possible. So it was just more of a clarification. It's not like we need to do a formal assessment of it, but just or maybe we do, but it's all up to you. It's just, we didn't have enough information on that. We thought it was an important aspect of the system.
Yeah, I would just note who's conducting the assessment, and I think this would require a partnership with council level leadership.
Yeah, so, Sharon, thank you, Sharon, for your comment, and the comment is that this recommendation, be integrated with the core funding recommendation that we've already approved. That perhaps that recommendation, which was focused on the core funding, formula and contribution, consider local level funding for local health departments and include some of this language in that. Yeah, so it's really, exactly, that, thank you. So it's really a comprehensive study of local public health, or local health department funding, including the core funding model, as well as the local contribution. Okay. So we have a recommendation in front of us. If we would like to, go ahead, Chris. Can you speak, Chris?
Sure. I mean, I think this is a good idea. This like an independent assessment of like, where is the money coming from for all the different programs? I mean, this is what we talked about earlier with this inventory to guide decision makers, right? But I would just add that it would also be good to understand the impact, as much as it's measurable versus just a narrative. But like, I think, again, I haven't asked Mina specifically, but I asked Laura. I don't know that this, I know it's in process, but I don't know that this actually exists. It's like, if you ask any public health leader, what's the most impactful program that you have? It's not easy to get an answer. And what's the least impactful? And so I think, as a capital allocator or as a business leader, right, you're looking to add funding to the projects and programs that are working and stop doing the ones that aren't. And I just don't know that we know. And, in this day and age, we gotta at least have something. So, I mean, it's billions of dollars or hundreds of millions of dollars. So, I think the recommendation is good. I would just add the impact component as well as the funding component.
Thank you, Chris. And just, I think at the local level, in our own individual agencies, we're able to articulate, what are the most impactful programs and services we have in terms of health outcomes and change in metrics and so forth. But perhaps at the statewide level, like when we look across the entire state, we haven't aggregated some of that impact as much as we can.
So
I'm not sure if that's Commissioner, oh, sorry. go ahead.
Is the motion to move it to consolidate this with another?
Right now, it's a standalone recommendation. If we'd rather vote on moving this into and having our support team help us with collapsing this recommendation into the previous one, along with the additional language of impact that Chris was mentioning, we can vote on that instead.
I
So is
think
there
that
anybody
makes
who
sense.
wants to vote on just the singular recommendation?
Can I make one more?
Go ahead. Yeah, please.
When we're also looking at this, identify successful models that can be used in other settings. I think this should, maybe it's more an add-on later, but I think we should also look at national models too.
Mhm.
Because we have successful models in the county, but there are many, many more successful models across the state across the country that we can adapt. We should also look at those as well. I make a motion to put this into previous one.
Okay, do we have a second on that?
Second.
Thank you. And we'll move to
Consult with it.
right, a vote on so the vote then in front of the commissioners is consolidating this recommendation language with the additional verbiage of impact that Chris was describing and referencing the consideration of national models that Matt was mentioning into the prior adopted recommendation about a study of the core funding formula. Okay, all right, so we'll take a vote on that. Do you want me to do it generally or do you want me to do it through the poll?
Let's do it through the poll.
Okay, so we'll do that through the poll. Thanks, Jane.
I think just a couple votes.
Are any commissioners struggling to cast their vote?
Yeah, I got kicked out. Sorry, I gotta find the password again.
All right. If you, you're welcome to just message Shane too, if that's easier.
11-0, this passes, or excuse me, advances to the slate as amended to consolidate with FND 054. Revisit for a comprehensive study that includes impact and return on investment analysis and considers national models.
Thank you. Okay, all right. We'll move to the last recommendation for advancement to, potential advancement to the slate. And this is about the public health and primary care continuum. We had some discussion around primary care and the role of local health departments at the prior meeting. And so this is a revision response to that discussion. Any comments from the commissioners in the room?
Is the recommendation just to acknowledge and support?
Dan?
If the recommendation is to acknowledge and support, like it's not actually, is there much action to it? Like supporting is that,
Yes, right.
it
The
financial? Is that-
recommendation is acknowledge and support. If you're suggesting something more, such as increased funding or something like that, then we would need to change the language of the recommendation. But this is more general with a, a lot of things could be captured under support.
Yeah, I think it seems non-specific to me. Like it doesn't have it doesn't have a lot of legs to it.
How would you strengthen it? If you agree with the general intent of it?
I mean, I think I would say acknowledge and support through funding and resources. Maryland Local Health Department's provision of basic care, and then probably the rest of it. It's got to be something with some teeth, otherwise. But I think this also in some ways ties into core funding. Is core funding for this purpose as well, or is this a separate
Right now.
product? It's not, but are we asking for a separate pot of money for those who need to do primary care? Foundations of public health are moving away from direct care, but this is acknowledging, which is true, that if there is no primary care, somebody's got to do it, and it's the health department that's more likely to do it, but you can entice a partner to come into it.
Any thoughts from, did you want to talk?
Yeah. I mean, I think that that's sort of focuses on the issue of primary care of sorts is provided in the counties. At this point, the Maryland payment model and the initiatives is incorporating and considering primary care as well as in part of the previous AHEAD model concept. And so that this part of what the counties are contributing to become part and parcel of the consideration of the state's innovative healthcare reforms.
So to strengthen the intent, and with that information in mind, would this then be
A funding component could be incorporated within this and a part of the planning in terms of this care being provided.
I see two comments, Sharon and then Chris. Sharon, go ahead.
So I suppose just in general, how are we defining insufficient access? What is determining that? So are we talking about rural counties? Are we talking about a data point? What does that mean exactly? Counties where there is insufficient access to healthcare. How is that determined?
So there's a variety of metrics that look at primary care access. You could look at federal designations for like health professional shortage areas. You could look at what the state has designated as areas of need. But I think I can't speak with every county. I know in our county, we look heavily at the federal designation of the health professional shortage area. Yeah. But there are qualitative aspects to insufficient access to healthcare as well, right? I mean, there are feedback from residents and so forth that we gather during our community health assessments that point out whether access to healthcare is adequate in particular parts of our county, and whether people are able to afford that care or transport to that care.
Sure, thank you.
Chris, you had a comment?
Yeah, I mean, I wrote it down. I just want to, I mean, we need more primary care, all hands on deck, but I don't know that the state health department is gonna do a better job delivering care than private sector. I could be totally wrong about that, you guys know, but I just, I would just somehow, I think this is fine. I think it's fairly benign. But I have concerns. So if somebody could just explain why do we, this is just like go team, like cheerleading? What do we?
Give an example if that's helpful, because, I'm in a county that has a significant lack of access to primary care. And just to clarify, it's not the state health department, it's the local health departments that this recommendation is talking about. And I would say that, in our county, we established primary care services, although they're not designated as a primary care clinic according to the advanced primary care requirements and model that the state health department has adopted. But we do provide a variety of primary care services, and we serve as the ongoing point of primary care for many community members who otherwise have no other access to primary care. And partly because there are no other access points in our county, or previously there were no other access points in our county for individuals who were uninsured or underinsured. And even the people who had private health insurance, for example, or Medicaid, weren't able to access primary care adequately. They had 6-month, 8-month waits, et cetera. And so we actually implemented 2 initiatives. One, we really tried to recruit entities to come in and provide primary care services and support those entities, in particular FQHCs. And we were successful in getting an FQHC established in the health professional shortage area of our county. But that took some time. They actually just opened up and launched, and I suspect they will be beyond capacity quite quickly. But alongside that, we looked at other models, such as school-based health centers, being a location of primary care services that help augment the total primary care capacity in our county. And we did step in to get that service line going. And of course, part of our role as chief health strategist is to continually monitor where there may be other partners in the private sector who we could support and as they establish and advance to meet the community need, or where there may be an opportunity to transition some of the work that we're doing into the private sector. So we do that all the time anyways. I think this isn't an intention for government to take over providing all the clinical care in a community. I think this is an intent for public health to serve its role of incentivizing partners to fill the gaps or step in and fill the gaps if those incentives haven't been working.
Do you have any audience with the rate setter? I mean, that whole MD PCP, this is like one of their big focused areas, is trying to fix this problem.
And maybe Dr. Crum can talk more to that. Actually, Chad Perman just came for a site visit to our health department last week. So we did have an opportunity to talk with him. He's the lead, and I know he's come in front of the commission to talk about the advanced primary care office at MDH. The incentives and so forth built through that system are really geared towards full scope primary care practices that are labeled as primary care, right? That are not operating as quote unquote public health clinics, even if they're also providing primary care services. I think the intent of this recommendation is to acknowledge that local health departments may need to provide primary care services in communities where there are shortages, but not so essentially to not restrict local health departments from providing primary care services if those services and if their work to address those needs can be useful in their community. But I'll pass it over to Dr. Crum to talk more.
So I wonder if you had earlier the recommendation around the public or the primary care workforce, and there's this piece here. It seems like there's something around more of workforce, number of providers, types of providers, who provides the care models. There's more of a comprehensive And maybe you put,
Evaluation.
right, there's health department that has to play a key role in a community of making,
Mhm.
of sort of setting that strategy, because you're also identifying where there are gaps in
Right.
access or where coverage doesn't equal access and care. So I'm wondering if there's some, I don't wanna amend too much or try to collapse things, but it seems like there's a lot here just within the primary care strategic work for how we then have sufficient supply and models to support.
The needs of the community.
Yeah.
So are you recommending that perhaps we look at combining this recommendation with the previous one and rather than just funding an assessment, we could establish a task force?
I just
or
think it's hard to
something?
separate the workforce piece and the supply side with your models, because you might need different models of care, as
Mhm.
you saw in school-based health centers or example. There might be other things that are needed.
Mhm.
Um, and maybe it's not the local health department is providing the care.
Right.
Maybe they're doing the connections partnership, or
Right,
maybe
where
they're
we're
providing
steering
the care,
the
right?
overall plan, right?
But something where you, I get your point here about it's the local health department at the center, right? To help create that strategy.
Health strategist.
Mhm.
Okay. Nicole agrees. Good thought. So in terms of kind of next steps though, and an actual recommendation. Operationalize it. Are we looking at combining two recommendations and making a task force, or are we looking at MDH care office leading a collaborative assessment and
Is there a way to,
recommendation?
this seems more like a soft acknowledgement, to be honest.
Okay.
And but I agree with it, the sentiment behind it, because we do provide a lot of primary care and the primary care we provide should be equal to the primary care that's provided by by a primary care office. But I'm wondering if you can just put language in another one of the recommendations around basic primary care about health departments and other providers of primary care, and that way it brings them to the same conversation that there is a continuum there of both sides of providing the primary care.
Okay.
I don't know how else to say that.
Yeah, no, I agree. I mean, Chris, go for it. Please speak up. It's hard to read the comment, that's why.
Yeah, I mean, I think this is very it's basically saying, hey, look, we want to fix the incentives, but in the meantime, we're going to take care of it ourselves if we have to.
Okay. So we need to get to a place of operationalizing. We can either vote on just this recommendation as is, or we could consider, like we did the previous one, collapsing it with the prior primary care recommendation and ask our support team to assist us with the language. We could say that we would like to establish and fund a task force or commission or study if something like that doesn't already exist. To address that. Go ahead.
I'm just thinking that we are linking different recommendations as we go through that will have to be looked at together in terms of how they will be implemented. These could be linked, for example. And then during the public comment period, I'll probably allow a little more thoughtful and time would be available to look at how best to configure it. Because I think it might take a little bit more time to think about what the specifics would be. And I like the suggestion of being very direct on who's going to be responsible and if there are resources going to be requested for it. So I would recommend going ahead with this, as you said, a soft one, but link it to the previous one on primary care so that we're looking at placing these recommendations for public comment together that are similar so that when people look at them, they see them as a coupling or at least a theme that's emerging.
There's a primary care commission, right? Primary care.
There's a primary care council. There was something from the MHC, the Maryland Healthcare Commission.
Yeah.
Working on primary care investment.
Yeah, so would it be reasonable to have the acknowledgement be for the HSCRC primary care group to acknowledge that public health entities are also in that primary care mix. I don't know if they do that already, but that way, at least the body that
Right.
recommends it and sets the regulations is also acknowledging that public health entities are also providing primary care.
So, so would we then rephrase this recommendation? Or, you know, Dushanka also had the point that we could adopt this, link it,
Oh,
and through the, you know, provision of public comments, gather feedback where we can perhaps revise this to be more substantive. Yeah, okay.
To wait.
Yeah, so, but that's a good thought, and I think we should keep that in our minds for some potential idea of how this might be best explored. And maybe this is also what could be discussed in the narrative, is how do we have our established primary care incentive mechanisms acknowledge and support Maryland's local department's provision of basic primary care services. So maybe they're the executor to some degree of something like that. Okay. Go ahead.
Sorry, no, just, so I get it, the support, we want to support and acknowledge the good work that our health department does, but are we not trying to also give them more financial support and strengthen that?
I think that's good.
Or we moving away from it?
No, I think that's covered under the
That's
word
covered,
support. I
okay.
mean, that's part of the softness and the general, you know, there's a lot of ways to support. Some of this followed the prior conversation from last meeting where I think there was some question as to whether local health departments should be providing primary care services at all. And I think this was somewhat in response to some of that conversation. Okay, all right, we're gonna move to vote on this with the understanding that this is gonna get linked to other primary care related recommendations, and that our support team and as we receive public comments, will consider how to make this more you know, how to execute this better in terms of, you know, where it would fit in best into the system that we have. Okay. All right, let's move to a poll, and then after this, we'll take a 10-minute break, and then we'll move into discussion and slate. You want to just, you want to refresh?
Well, yeah, just did.
Okay, are we?
Right, 9-1, it advances to the slate.
Okay, thank you. We've now considered all 6 of those recommendations. They've all in some format have advanced to the slate, and we'll take a quick 10-minute break and reconvene at 3:40 for discussion and then consideration of the slate. Thank you. Okay. Thank you. All right, let's go ahead and restart. Thank you again for everybody who's staying with us and for our listeners, for your
Good way of doing
patience as we work through this whole process.
it.
Okay, so we're gonna move on to the next part. So now this is discussion of the full slate that we've come to in our process of reviewing individual recommendations. So we all the full slate of recommendations, including the 6 that we've just adopted in some format, are for our consideration. And commissioners, all of these materials have been sent to you in advance in your emails. What we'll do today is one discussion of the full slate of recommendations. Now that you have all of them in front of you, if you could please share any thoughts, concerns, or remarks you might have to the full slate in consideration with these questions that we have up on the screen for you. One, noting if there are any conflicts, duplication, or concerning language conflicts between the recommendations now that we have the advantage of the full slate. Is there anything that is causing major concern? And you know, again, with the caveat that we have already individually considered each recommendation and voted upon those recommendations. So the idea here is that there kind of a thematic concern that we're having across those recommendations. And then is there you know, any significant gaps in areas that we haven't addressed that the legislation had asked us to address? So if you could please take a look at your materials, and hopefully you've had the chance already to review them. But if you could please take a look at the materials and provide some remarks, we will take those now. We'd love to hear your voices. In looking at the entire slate, maybe let's just start piece by piece. In looking at the entire slate, are there any duplicative or conflicting recommendations that we need to tune into?
Are there any significant changes from when we voted? I know we sort of said we adjust some of them.
There were some refinements to the language that we shared in the draft that I sent out yesterday, partially because we, as a support team, took the recommendations and tried to group them somewhat thematically within the work group structure, and to provide a bit more consistency in how they were presented. So for example, generally speaking, the recommendations now will begin with an action verb for the most part, and there might have been some minor tweaks to clarify or make it clear different actors or people involved, but nothing should have change that would have substantively altered the impact or spirit of the recommendation. And so to the extent that there may be something of that nature, there certainly is opportunity within the open comment period to flag that or to send note to the support staff, and we will take a look and see if you know, there was an issue there. But all the changes that you see really were to try and normalize and create some consistency or to add additional value in terms of connectivity to some of these different recommendations, particularly as we look at you know, duplications or overlap. Where might we have opportunity to winnow these down a bit further and have more impact?
Just so every commissioner gets a chance to provide comment or feedback or any thoughts if they have them. Is it okay if I grab, get the roster, if we still have that and this? Oh, sorry. Thanks. Thank you. If you don't mind, I'm just going to run through commissioners and then, sorry to put you on the spot, but I just want to make sure we have an opportunity for everybody to provide a comment if they have it, and if you don't, then that's fine too. But if you have any thoughts on the process or the general impression that you're getting of the entire slate, or any concerns that you have with the entire slate, if you could please comment upon that. And I'm going to start at the bottom of our roster this time, if that's all right. So Alan, go for it. You're first.
Yeah, just being first out. So, I think overall, I think the recommendations on the slate are comprehensive and represent, very thoughtful and meaningful work in this regard. I do not have any concerns at this time with the slate. And I would reserve any other remarks at this time.
Thank you, Al. Michelle, if you're on, Michelle Spencer.
She had to drop off.
Oh, she had to drop.
Graduation.
Oh, right. Sorry, graduation, of course. Nicole Rochester.
Hi, so I don't have any specific comments other than to say, this has been a gargantuan task, and I'm just very appreciative of fellow commissioners as well as all of the support we've received from, everyone in the room and those on the line. This is, I don't know that I envisioned, this end result when we started. But this has been great. I really appreciate the refinements to the actual process. It started out a little bit clunky with us trying to, the voting process, and you all have done such a wonderful job making the process easier. So really, I just have kudos. I don't have any constructive feedback other than to say it's been a real honor being involved in it. I think that the recommendations are extremely thoughtful, and I'm looking forward to getting the public comment. Thank you.
Thank you. Thank you. Tosin?
Yeah, I mean, it's just really kudos to everyone for how far we've come with this recommendation. Seeing the slates just justifies the depths, of work that we put into this process. I think the thematic groupings is the beginning of how the final report is, probably going to look like. So I think this is nice. And, we'll talk more about how this will be further refined, but I think we're at a very good spot here, and we can only build on it till we get to the final lap. So thanks. Yeah.
Dr. Crum, I know you're new to this process, so I'm not sure if you have thoughts to share, but please, if you do, feel free.
I mean, I echo the comments of just the body of work and all the effort that went into it. It's really impressive. We can certainly share. I think we noted just a few items that look like maybe they were duplicative.
Okay.
And then just given the federal climate, some of the recommendations, I'm not sure what's feasible, just with some of the changes. So I want to be mindful of that. And even, I mean, we don't disagree with some of the Medicaid related recommendations, but at the same time that requires federal approval, and we're just not sure what's possible there.
Yeah, and that's a great comment. And actually that have come up several times, is the federal climate, the funding climate, the budget crisis in the state, et cetera. And I think, they need video. Sorry, Shane, I guess it's still on. Or Michelle, whoever's sharing the screen. Thank you, Dr. Rochester. The kind of the sentiment that we've arrived at is this assessment and these recommendations are somewhat just more looking at the system and seeing what needs to be improved. Because this may be something we look at 5 years from now, 10 years from now, et cetera, under different climates and different funding paradigms. So it is something that we're tasked to make recommendations for the system, and we'll have to navigate whatever those funding climates might be, in figuring out how to implement, from those recommendations, but that it may take some time to implement some of these recommendations. But thank you. And for any duplications or notes, since we're voting on the slate now, if there's any substantive duplication where we need to just completely remove a recommendation, it would be good to note that. But if it's more tweaking of language, that's also something we can look to MDH to provide that feedback during the public comment period as well. Thank you. I don't know if Dr. Lushniak is talking, but I think his proxy is Dr. So,
you know, I can add something.
Letters. Dushak is so disappointed she can't talk now. Oh, we're great, but it's great to have you, Boris. I think you're saving lots of boats and lives.
Oh, you're on mute.
You're on mute. Mute.
Anyhow, it is a unique scenario being here at a lighthouse, right? And you know, I always like the world of metaphors because I think to a large extent we are that beacon as a commission, you know, for bettering public health. You know, obviously I'm supportive of the slate as it stands. I think the incredible work of our working groups sort of has come to prime, but also the feedback and the activism of each of the commissioners. And so I will allow Dushanka to say something as well, because she is my proxy today. I realize that I may not be connected fully, even though I'm at a lighthouse, but it's on Lake Huron, and it's a beautiful day here. There was fog this morning, but it's lifted now. So we're in good hands here, as I feel we are with this slate of recommendations. I'm also very eager to see what the public feedback is going to be, and what another time period for even us as commissioners to have another look, right? We are part of the public. We've been emphasizing that. So if there is further feedback, we do want to hear from people. So thank you for everything you've all done. Thank you.
Boris, it's great to hear your voice. Thank you. Appreciate it. Stay safe out there. Dushanka, please.
Oh, thank you. Thank you, Boris. I wanted to also sort of reaffirm what Boris said, but also emphasize the importance of priority setting. And we see that as the next page for the commission to set priorities among these wonderful recommendations. And also the part of the discussion, the first part of this meeting that focused on who's going to take the action, how much, what resources are needed. Those are the specific aspects that need to be done for each recommendation that exists, or combination of recommendations. So I'm looking forward to that phase.
Thank you. Okay, Sharon, if you're still on, I know you're proxy for the Deputy Secretary Lord.
I'm still here. I don't have anything to add. I know that she did add some comments in one of the documents that Vanessa sent over yesterday. So thank you.
Matt Levy.
I don't have anything to add at the moment. I think it's a very long list of recommendations. I think it shows a tremendous amount of work and commitment to this. I agree that we need to prioritize this. Is it 65 recommendations?
I think 61.
So that's a lot for legislators, other than
Although they're not all for the legislature.
other than Senator Lamb, that you know, and it's a lot to process.
And delegate back.
And delegate back. Yes, sorry. So I think it is important for us to prioritize. Some of them do have a lot of overlap in some ways, but I think they're we're building a full picture of what the need is and where we think we should be heading. So I think it's great. And I think it will be important to hear the public comment and then incorporate that into this, because we're looking at the lens of the Public Health Commission and not the lens of the public. So
Good point. Thank you. Senator Lamb.
Yeah, I mean, I think it was mentioned during the break, in many ways, this is an aspirational document, right? We understand there's limitations, there's funding limitations, there's limitations of resources and whatnot. But I think it lays out a roadmap knowing that this is not just for 1 year, but this is something that could extend quite a ways beyond that. And it's aspirational for that reason, that we can continually chip away at it to, the point there, it is one where we do probably want to have some prioritization, because that would be helpful for us, as we try to figure out what we can pick off first. But it does give us an ability to kind of downscope to other things that we might need to work on later. So, appreciate the thought, and all of this is, I know a lot of work went into the work groups to make this happen.
Thank you. Thank you, Senator. Jean Drummond.
Yeah, so I echo a lot of the comments from my colleagues. When I look at it and I think about, from policy to practice, I think about the entire healthcare system, healthcare ecosystem. I mean, it's very comprehensive. I mean, from Medicaid, just the workforce issues. I guess the only little piece is, and maybe I've missed it. I think definitely we've had the opportunity, although the public has not yet commented on this. I think a lot of it says, the members, the public's voice, but I'm also thoughtful about the clinicians as well, because at the end of the day, the plans, the entire, I think, healthcare system hinges largely on the providers, right? We can't get quality med, just all of this. And so have they really had that voice? I know many of us around are doctors, but you got that public health way. You know what I'm saying? So I'm thoughtful of that community-based clinic, that FQ, and just their voices. So, but from the AI, the data, I think we have, it's the pie, and we're slicing it up into all the aspects. It's quite audacious, and so no question, priorities will probably be a little painful for us to come through. But I think the research of the subcommittees has been phenomenal. You've definitely given a broad lens to our policymakers and funders and all those things. I even know the foundation, we've got foundations, no dollar unturned, right, on where we could possibly get money.
Great, thank you. I'm gonna go to Chris.
I would want to express gratitude to the chairs and to the work group chairs that have really shouldered a ton of the burden on this. And it's a privilege to be able to engage with all of you and to be able to provide some comments. So thank you all.
Thank you. Camille Blake-Fall.
Yes, thank you. I concur with the sentiments and perspectives offered by my colleagues at MDH and have nothing additional to add. Thank you.
And Delegate Bagnall? She's still on.
I don't know if she is.
I just in deliberative process, the years of expertise that have gone into this document are extraordinary. And I think we have struck up, a balance between aspirational and actionable. And I'm looking forward to
Delegate, we missed the last part of your comment, but I think we grasped the majority of it.
to the public comment.
I think we may have
in the prioritization. So just saying.
So we're hearing you're looking forward to the public comment and the some prioritization. I'm hearing.
Was I picking up? Are you?
Yeah, we're not able to get the full note, but if you'd like to type anything, feel free. I think the audio is breaking up quite a bit, but thank you, Delegate. I think your and Senator Lamb's advocacy for this commission in its onset was such a, I mean, is what started it all. So we appreciate all of that work and your ongoing involvement in the commission. Okay, my thoughts are really just echoing everybody else's. I have some incredible deep gratitude to all of the commissioners, the fantastic support team who have been working with this commission and in various ways, all the work group co-chairs, and of course, all of the amazing work group members who've dedicated so much time and thought into making this a very well thought out, I thought, and constructive process. I'm really looking forward to public comments. I know we've received some of them already. I also am deeply grateful for our assessment team who carried so much burden, I think, during their already normal jobs, and making sure that the assessment was hearing the voices across the state relevant to getting a better understanding of our existing public health system and hearing potential recommendations from that assessment process. So thank you for everyone who's been involved. I also feel like it's a fairly comprehensive set of recommendations. I do think there's some linkages and exploration of context that we can do in the narrative portion of the final report that will shed more light, that will discuss priorities and prioritization of some of these recommendations. And certainly, as the comment was raised before, we'll take some opportunity in the next month or so to explore further what kind of fiscal impact some of these recommendations would have. And expect that if they do come up for consideration as policy, then some of that analysis will happen during that time as well. So thank you, everyone. We're going to now move. Appreciate everybody's thoughts and comments. And if you have other thoughts or comments that you didn't get to that you'd like to provide separately, please feel free to send it to the commission email or to call any of us who are co-chairs so we can chat with you directly. But now we're going to move to review of the final slate and to hopefully take some action that will advance recommendations into the public comment period. Again, just as a reminder, we have already considered and voted upon each individual recommendation previously, but if there are consensus decisions to remove something because it duplicates or conflicts or so forth, then we can certainly take that action as a commission before we vote on a slate. We're going to do the final slate by work group, and then also have some of the cross-cutting recommendations that we've considered as its own category. So Shane's going to advance us through the slate of recommendations per work group. It just kind of makes it into chunks for us so we can vote on moving them to public hearing or public comment period.
Okay, first up, obviously going alphabetically, is the communications and public engagement draft slate. So the question before us is the communications and public engagement draft slate adopted and approved to release for open comment as presented, which would be the document that was sent with yesterday's materials. And based on our records, these recommendations cited here by recommendation number as well as title are what we are tracking as being part of that. So if there are any errors or omissions, please let us know, but this is what we believe to be the slate as previously voted upon.
Okay. So at this point, if I'll take a motion for adoption, and then we can move into a discussion period. Thank you, Delegate Bagnell. We got your comments. That's very, very kind of you, and really, again, appreciate your extensive involvement, ongoing involvement with the commission. And then we can move into discussion and then move into the voting for having this shifted to public comment. So I'll take a motion if anybody wants to make it. Make a motion. So moved to move to public comment.
To accept the community and public engagement recommendations to a forward for public comment.
Okay, thank you, Deshantha. Is there a second? Second? All right, so we'll move into discussion. Is there any additional discussion that needs to happen on the slate in front of you relative to this work group?
So can I just ask this? So all of these
We voted on already.
we voted on already. They will all go out.
They will all go to public comment if the motion carries.
Okay.
But right now, we're voting to move all of the recommendations that we
Yeah.
have individually voted on already.
Right.
To move them to the public comment period.
Okay. Okay.
And just, sorry to interrupt, Tosin, but I want to clarify and make sure that folks understand that we are offering for public comment a draft of the recommendations. These are not the final recommendations that will ultimately end up in the final report, because we do assume that through the open comment period, there will be feedback, there will be modifications that we'll take action on. And so I don't want folks to feel like they are being forced into, this is it and the ship has sailed. There's still opportunity for folks to influence this. But at least in terms of the sum and substance, this is what has been recommended by the work groups and accepted by the commission to move to that slate.
Okay.
So I wanted to clarify that.
Thank you.
No, I think once I see the pool, I just wanna see what it is.
Okay,
Yeah.
all right, sounds good. Okay, all right, hearing no further discussion, we'll move to a vote on this. And are we doing this by poll?
Yes.
Shane? All right, so we'll do this by poll, everyone. And this is again, moving this slate of recommendations to the public comment period.
Everyone voted. I'm missing a couple of votes.
Senator Lamb just stepped out, so I don't know if he's voting. Is there anybody online who has not voted?
There we go. 9 votes in favor of adopting the draft slate and releasing it for open comment. There were no nays.
Okay, thank you. All right, thank you, and we'll move to the next slate, or work group slate, I should say. So this is the individual recommendations that have been approved by the commission to be voted on today for moving to open comment. I'll take a motion if anybody's willing
I'll make a motion.
to move the public comment. Thank you.
Second.
Second on that. Thank you. Any discussion on this portion of the slate?
The only question I have is, are these all the recs from data and IT?
Yeah, this
Okay.
is the DIT.
Okay.
Okay, hearing none, we'll move to the poll. Polls open. Okay,
9-0. This is adopted and released for open comment.
great, thank you. We'll now move to the funding draft slate of recommendations. Again, all these recommendations have been individually considered, debated, voted upon by the commissioners.
And I will note this does include the
Ones that we talked about
the one
earlier.
that we did, yeah.
And thank you, Shane clarified if you didn't hear online, this does include the ones that we forwarded earlier today. Okay, I'll take a motion if anybody wants to make one.
I make a motion.
Okay.
The slate for funding recommendations be approved and moved to the public comment.
Second.
Thank you. All right, any discussion on these?
Or on Medicaid and federal.
Okay. Then, are there any other comments online?
Nothing from commissioners.
Okay, thank you. All right, so we'll move to the poll for voting.
Poll is open.
Poll is open. Thank you. Okay. I got some of the words. Not anaphylactic.
I'm missing a person, but it is 8 in favor of adopting and no nays.
Okay. All right, we'll move to the next slide. Thank you, commissioners. So this is the governance and organizational capabilities related recommendations. Again, all of these have been individually considered and voted upon by the commissioners. Take a motion if anybody wants to move.
If I could just make a quick note, the work group submitted updated language that was included in yesterday's packet around the co-creation model in recognition that there had been some lingering conversation about how best to operationalize that, and it did seek to address some of that. So that was highlighted in there and should be reflected.
Thank you.
All right, I move to adopt the GOC recs and approve them, release for open comments.
Thank you. Is there a second?
Second.
Thank you. All right, any discussion on this beyond what Shane shared?
Didn't we talk about the listserv as being something underneath as more of a function than a recommendation?
It had been brought up in discussion, but was ultimately forwarded to the slate.
Okay.
However, during open comment, it could be discussed that maybe it's better suited under collapse recommendation.
Okay. Any other comment or discussion? All right, well, hearing none, we'll move to the poll.
Poll is open.
Thank you, Shane. If all commissioners could please cast their votes. If you're having any trouble casting a vote, please let us know.
Okay. The slate is adopted and it approved to release with 8 yeas, 0 nays.
Thank you. Thank you, Shane. Okay, we'll move to the next, which is the workforce draft slate. These are all the workforce recommendations that were already individually considered and voted upon by the commissioners. Would anybody like to make a motion?
I make a motion for the workforce draft slate to be adopted and approved.
Great, we have a motion and a second. Thank you. Art
was the second.
Dushaka. Any, she was right. Any discussion on this slate? Any discussion on the slate from in the room or online, commissioners?
I just always thought the workforce had more. I don't know why. I thought workforce had more than so, but
I think
appears.
there's a lot
They-
of rationale in the paper.
Oh, I
think there are
see.
justifications for
Where
strong.
lengthy, yeah, okay.
In the language itself.
The language, which is helpful for the language, yeah. Okay. In volume, this is it, okay. You did the same, you're like, okay.
Okay, hearing no discussion, let's move to the poll.
Poll is open.
Thank you, Shane. If all commissioners could please cast their votes. If you're having trouble, just let us know, please.
Okay. The draft slate is adopted and approved for release with 9 in favor and no opposition.
Thank you. And then lastly, we have some of the cross-cutting recommendations, or were they already?
I went too far.
Okay, all right, no worries. No, I wasn't sure if we fit them underneath the work group. So, okay, so these are some of the cross-cutting recommendations that we have individually considered and advanced to this point, and including some of the ones we heard earlier today.
And I did note on here that 060 county level assessment and capacity building should be consolidated with F&D 054, the corresponding revisit, and 065 public health and primary care continuum should be linked with the primary care 055, which will be operationalized afterwards.
Thank you, Shane. Hopefully everybody online heard that. Okay, great. Thanks, Alan, for nodding your head. You're the only person I can see, so we're good. So, all right, great. So let's, I'll entertain a motion.
I move for us to adopt the cross-cutting recs, approve them and release them for open comment.
Is there a second?
Second.
Shanka, second?
I'm the second.
All you commissioners online are welcome to make motions and second them, but okay. So we'll move into discussion. Is there any further discussion on this group of recommendations beyond the additional comments that Shane's already made for us? Okay, anything online? Okay. All right, well, hearing no further discussion on these, we're going to move to the poll. And thank you, Shane.
Mine thinks doing something funky.
Yeah,
Is
it's
it- did it
fine.
reset?
Let's try
It keeps going off, okay.
Very.
If you refresh it all.
The cross-cutting recommendation adopted and approved 8-0.
Okay. All right. Wow, commissioners, thank you. Thank you, thank you. That was several months, so, and an incredible amount of work across the commission, including our support team and our work groups, and just great input into the process from the assessment team and individuals providing public comment during the listening session and response to surveys that we've issued. So thank you, everyone. This is a momentous occasion. And we're looking forward to the next phase, which is the public comment period, lasting 30 days. And then, of course, the final refinements to get these recommendations to a final state for the final report. we'll make some announcements. Just, again, the open comment period will start on Monday, or no later than Monday, I should say, June 9th, and continue on for 30 days. The next monthly meeting of the commission is on July 10th, and that will be here with a hybrid option. And that will be after the public comment period has finished. So we'll have a chance to see where we are at that point. Of course, we won't be in a place of having final revisions or anything at that point, but we will be able to consider and review some of those public comments, which will be considered also at the work group level. Just, kind of keep in mind, I know you all have these in your calendar invites, but keep in mind that our remaining meetings of the commission prior to the publication of the final report are July 10th, August 21st, September 11th. September 11th is a virtual only meeting. And then September 25th, which is the last meeting we have, the last opportunity we have to adopt formally as a commission the final report, so we can then share it with the legislature and the governor.
Where do we anticipate the report to be written, the draft?
It's already in process. So a lot of the background narrative of the report is already being fleshed out. Our support team has been working hard on that. And the writing will continue over the next few months with where, we kind of map out the whole story and timeline and narrative and rationale that were submitted with some of these work group recommendations. Of course, after the public comment period, we'll have a greater opportunity to include in that writing the state of the final recommendations, the rationale for those recommendations, the weaving, the prioritization, the narrative to accompany those recommendations. Yeah, I think we'll be considering drafts of the final report, though, probably during September, late August, September, as a commission. Okay. Any other announcements or key comments from our commissioners, from our support team members? Great, everybody's ready to escape the heat and go out into hotter weather.
I would just reiterate, I mentioned this earlier, but for that final meeting, I think, in true celebration of the effort, it would be great if we could, as many of us, be in person for that, so we can truly acknowledge the work that went into this, particularly you folks who are, for the most part, volunteers and dedicating your time and effort on top of your day jobs, right? So I think that's a significant thing to acknowledge.
Thank you. Thank you, Shane, for saying that. So September 25th, everyone, please, if you can, try to be in person for that. All right. Well, congratulations. This is really great. I did not expect us to do this before 4:30, much less before 5. That's phenomenal. I don't think we had a meeting that ended before time, but I feel like it was a good discussion. We had an opportunity for all the commissioners present to provide some comment and discuss feedback. And I just, again, really tremendous work. Really, really, really appreciate the incredible dedication and wisdom and expertise that's contributed to this process. So thank you, everyone, for all of that so far. And we'll see what the public comment brings us. We'll see you all in July as well. Enjoy your June.
Thanks.
Thanks. Oh, we got to have a motion to adjourn. I'm sorry.
I move.
Thank you. Second.
I'll say.
All right. All commissioners in favor of adjournment of the meeting?
Yeah.
Everybody else not? Great, Alan. Thank you. All right. We are adjourned. Thank you. And Boris, stay safe.